Okay, well, we might make a start, I think. I'm not sure whether you can see me or not, but I've got my camera on, don't know why. Um, Today I wanted to talk about bleeding disorders in children, and we've talked before about anemia, and we've talked about um, hematological malignancies, but we haven't talked about bleeding disorders, and we haven't talked about that that issue of bleeding and coagulation. So I thought we'd just talk about common bleeding disorders in children because they are collectively they are quite common, and we see children with either acquired or inherited bleeding disorders relatively commonly. The ones we'll talk about today, these are the sorts of conditions that are they're uncommon. Collectively, they're not that uncommon. Uh, First of all, idiopathic thrombocytopenic purpura, which is the commonest platelet disorder in children, relatively common, uh, associated with viral infections. Von Willebrand's disease is also a platelet disorder, but it's about not so much that you have low platelets, but the platelets can't adhere to the endothelial cell wall when there's a breach in the endothelium of the of a blood vessel. And then there's inherited coagulation disorders like hemophilia or like von Willebrand's disease. That's an inherited condition. And we'll talk about the differences between the two of those common inherited conditions. And we'll talk about vitamin K deficiency, especially in the newborn period, and we'll talk about why some babies are more likely to get vitamin K deficiency than others. But we'll also talk about how vitamin K deficiency can be a feature of lots of other conditions we look after in children, whether it's that they're not ingesting enough vitamin K because they're undernourished, or starved for a week or so, you can still get vitamin K deficiency, or that they're ingesting enough, but they're malabsorbing the vitamin K deficient, the vitamin K, and that might be because they've got liver disease and you need bile salts to absorb vitamin K. But it also might be any other form of malabsorption where there can also be vitamin K deficiency, and that can lead to a coagulopathy. We'll talk about um, sequestration of platelets. We'll talk about disseminated intravascular coagulation, and we'll briefly mention dengue. So as I say, collectively, these bleeding disorders are relatively common, and we see it every week or so in the wards. A child who's got some cause of excessive or unusual bleeding. This is on the left is a small infant who had an infection, a viral infection, and you can probably see the petechiae on the baby's skin, just small red dots. These are petechiae, and that is common in immune thrombocytopenic purpura, especially when you've got a platelet count of less than 50 or even less than 30, and the child on the right has not so much petechiae. You can see a few little petechiae, but you can more see purpura. Now, I want to show these pictures at the start so you understand the difference between petechiae and purpura. The child on the right has purpura, uh, and they're more like what we call it's bleeding into the skin. Uh, um, Petechiae is also bleeding into the skin, but it's microscopic. It's at the level of just having, usually due to low platelets, and typically this purpura can be due to low platelets, or it can be due to other things like vascular coagulation or like a coagulation abnormality. Idiopathic thrombocytopenic purpura, ITP, is the commonest platelet disorder of children. And even though it's the commonest, it still only occurs in about 1 in 10,000 children. But we'll see it, every several times a year. We would see a child who's had a recent viral infection, then they they develop petechiae. Sometimes they get more than petechiae. Sometimes they get purpura as well. Sometimes they'll have bleeding from their nose, mucosal surfaces from their nose and the gastrointestinal tract, or they may have bleeding from in their urine, or if it's an older child, they may have menorrhagia. So the areas where a child with ITP can bleed are many, but usually it's just skin and mucosa, but sometimes it's more deeper into the organs or the soft tissues. The way to make a diagnosis of ITP is by excluding all the other dangerous conditions that children might have, causing bleeding and causing thrombocytopenia. And so the definition of a child with ITP is only a child who's got a low platelet count, but has got no lymph node enlargement, no spleen enlargement or liver enlargement that might make you think that the child's got a hematological malignancy. And then you need to look out for red flags for an alternative diagnosis, such as if they had leukemia, they might have bone pain, or they might have a limp or anorexia or weight loss or jaundice. So there's lots of other causes of thrombocytopenia, but we just have to put in the effort to make a distinction between them and the otherwise well child who's had infection, has a low platelet count, but has no evidence of a hematological malignancy. So looking for these things: bone pain, looking for rash or arthritis or myalgias or recurrent infections or fever that might suggest there's something else going on, and asking about a family history of bleeding disorders. Usually with ITP, there's no family history, but a child who presents with excessive bleeding, gastrointestinal, mucosal bleeding, purpura, might have an inherited disorder of coagulation, like hemophilia or like von Willebrand's disease. So our job is really to exclude all the other dangerous conditions, and then you arrive at the diagnosis of ITP. And it's only then that you can start to decide on what treatment a child with ITP needs once you've excluded all those other conditions. The differential ITP is, as I said, leukemia or bacterial infection. A child who looks very unwell with a fever and they look toxic may well just have bacterial sepsis rather than ITP. Unfortunately, we do see children who've had like trauma and they've got bruising and bleeding because of that. And clearly, if a child's been in a motor vehicle accident or something, if they've been hit by a car or they've had a big fall, then you know that they've got trauma. But in a child with unexpected bruising or bleeding, then you just have to keep in mind that yes, it's possible they've had trauma and the parents or the caregivers are not actually telling us about it. So occasionally you see a child with traumatic bruising and bleeding, and you might think it could be ITP, but actually it's more like trauma. And so a non-accidental injury is possible. Like leukemia, you need to exclude aplastic anemia before you make a diagnosis of ITP. And the way to exclude aplastic anemia is simply to look at the rest of the blood film, and the hemoglobin should be okay, the red cell count should be okay, the white cell count should be okay. And if the child had aplastic anemia, they'd have more than just the platelets. All three cell lines would be down, or more than one cell line would be down. It isn't just the platelets. By cell lines, I mean you've got red cells, a red cell line, a white cell line, and a platelet line within the bone marrow. And if you've got all three cell lines down, then you've got some form of marrow aplasia. It might be aplastic anemia, it could be leukemia. But if you've only got one cell line that's down, then like just thrombocytopenia, then it could be due to ITP. There's some other conditions that will give you the features of ITP. So systemic lupus erythematosus, it's the great mimicker of conditions. And again, you just need to exclude other features like a rash or something else that might suggest arthritis or joint swelling that might suggest SLE as a cause of thrombocytopenia. And then, of course, there's drugs that cause thrombocytopenia, particularly non-steroidal anti-inflammatory drugs. They're the most common cause of thrombocytopenia. And then there's some rare conditions, and to exclude them, you just need to think, well, is there any other features of hemolytic uremic syndrome or thrombotic thrombocytopenic purpura? And those features are typically the child's in kidney failure, and they have hemolysis, so their hemoglobin is usually low. And it's not that their bone marrow stopped working, it's just that they've got intravascular hemolysis. And they're almost always hypertensive, and they almost always have headaches. So kidney failure, hemolysis, hypertension, and headaches, you should think of hemolytic uremic syndrome or TTP, which is thrombotic thrombocytopenic purpura. They're two rare conditions, much less common than ITP, but just in your assessment of the child, you should try to exclude those conditions. And once you've excluded those things, then you're back to a diagnosis of likely ITP, and you can then treat the condition. I said the most common place in which ITP bleeds, children with ITP bleed, is their skin, just with petechiae or purpura, and their mucous membranes, their mouth or their gastrointestinal tract, sometimes their urine, and sometimes, if in an older girl, menorrhagia, but sometimes vital organ bleeding can occur. An intracranial hemorrhage, the risk is very low. It's less than 1%. It's usually with trauma, but not always. Certainly other serious bleeding can occur, like bleeding into the liver or bleeding into the lungs can occur. Usually we don't transfuse patients with ITP unless their platelet count's less than 20. I usually transfuse them if they're less than 20, especially if they're toddlers who are playing and might fall over. And so unless they've got severe bleeding or their platelet count's less than 20, I try not to transfuse them, because when you transfuse platelets in a child with ITP, they just get consumed anyway, usually by the antibody that's binding to the platelets. So the platelets don't last very long. But if the child's bleeding, or they're toddlers, or they're likely to have falls and injure themselves, then I usually transfuse them, certainly below 20,000. We usually treat based on symptoms, treat ITP based on symptoms, and the treatment is usually, excuse me. Oh, that's Trevor Dew. Yeah, I'm just giving a lecture at the moment. Would you mind calling what's happening with him? Okay, Mahmood or the guys are around. They'll come and have a look at him first, and then I'll come. But I'm just giving a lecture at the moment. Sorry. Can you call Mahmood, please? Thank you. Sorry. Yeah, you usually treat ITP if there are based on symptoms. And so if a child's got, certainly toddlers and young children, I would treat them with steroids, 2 milligrams per kilogram for 4 to 7 days. Sometimes it has to go a bit longer, and you, after the first week, after 7 days, then you can taper off, go to 1.5 milligrams or 1 milligram. Sometimes you have to taper off over 3 to 4 weeks. There's also another therapy called intravenous immunoglobulin, which is a blood product, immunoglobulin, that also treats ITP. Mostly, though, children will, if it's only mild, if their platelet count's over 50,000, if they only have petechiae, then usually that will resolve over the coming weeks. Usually the thrombocytopenia resolves over the coming weeks. By 6 months, 3/4 of the children have completely resolved. They've gone into spontaneous remission of their ITP, but about 10% progress to chronic ITP. It's not very common, but about 10% progress to chronic ITP, which means that they've got thrombocytopenia for more than 12 months. If a child's got significant bleeding, then steroids, often high dose steroids, 2 milligrams per kilogram, plus using tranexamic acid. And then if you've got access to immunoglobulin, giving that as well. But that's if they've got significant active bleeding, then you do that. Otherwise, just treat them with, if they're relatively asymptomatic, then just treat them with steroids for 4 to 7 days, and then a weaning after that. I wanted to talk about, that's ITP, the commonest condition, but I wanted to talk about inherited coagulation disorders, because there are certainly children in PNG and elsewhere in the Pacific that have inherited coagulation disorders. I think probably von Willebrand's disease is a little bit more common than haemophilia, but there are some children with haemophilia as well. So let's go through the differences between haemophilia and von Willebrand's disease, and hopefully it'll help you. This was a child who's got haemophilia, and again, the characteristic feature is that they bleed into their joints. That's typical with haemophilia. It's an X-linked condition, and we've talked about this in the talks on genetics before, and X-linked conditions almost exclusively involve males, boys, and sometimes that it appears to skip a generation because the affected boy will get the mutated gene from his mother, and the mother will have got it from usually a male member who was also affected. So it appears to skip a generation, and often the grandparents or the great uncles might be affected, but not the parents usually. On the other hand, about a quarter of the cases of haemophilia are new mutations. They're sporadic mutations. And then what that means is that there may be no one in the family affected. There's just been a new mutation or it went unrecognized. And so don't think just because there's no family history that it couldn't be haemophilia. But the characteristic is that they get bleeding into their joints, typically the knees, but also other joints as well. Children with haemophilia often have one particular joint they're more likely to bleed into, but they may bleed into their muscles as well. So you can get bruising of muscles and swelling of muscles, and subcutaneous tissue with purpura or petechiae. If the haemophilia is very severe, then they may get intracranial bleeding, and in the first few weeks of life, they might have had umbilical bleeding from the umbilical cord. And the severity of the bleeding is dictated by the percentage of factor VIII that exists in the blood. And if you've got a child who's got frequent joint bleeding and bleeding into other vital organs, then they've probably got very severe factor VIII deficiency, and it's probably less than 1%. For many children with very severe haemophilia, their factor VIII level is less than 1%. If they've got 1 to 5% of their normal, what should be normal factor VIII, sometimes that's a bit protective, and the child doesn't get very severe bleeding, but sometimes they will with trauma. And then if they've got between 5 and 20%, that's usually pretty mild haemophilia, but they also may bleed with trauma or with surgery, and so sometimes we've had children who've had surgery, and it only becomes apparent at the time of surgery. It was by a prolonged partial thromboplastin time and excessive bleeding afterwards, and those sort of children may have mild haemophilia with a percentage of factor VIII of 15 or 20%, and so it's only affecting them when they have surgery or when they have trauma. The treatment for it is to replace the missing factors, and these days it used to be that there was pooled factor VIII, and then there came a time when they have what's called recombinant factor VIII, which is sort of artificial factor VIII, which is most children get that these days. The reason for that is because when we were giving pooled factor VIII, that is pooled from blood transfusions, then to give enough factor VIII, you have to give, it's like the equivalent of many different donors all combining their factor VIII, and that can lead to an increased risk of blood-borne viruses. So these days we give artificial factor VIII, which is highly effective, and if you don't have factor VIII, then giving fresh whole blood also obviously gives factor VIII, or giving fresh frozen plasma will also administer factor VIII. I wanted to talk about von Willebrand's disease because it's a little bit more, I think it's a bit more common in PNG, and there's certainly some families in the Highlands who have von Willebrand's disease. It's an autosomal dominant condition, so usually there's a family history, there's usually a first degree relative who's got excessive bleeding, or sometimes even a person who's died of bleeding or unexpected early deaths in children may point to von Willebrand's disease. Usually that you can make the distinction between haemophilia and von Willebrand's disease, because children with von Willebrand's disease don't usually have hemarthrosis. They don't bleed into their joints. They usually bleed into their mucosa. So they'll get petechiae or purpura or gastrointestinal bleeding or post-traumatic hemorrhage or post-operative hemorrhage, or in older girls, then menorrhagia, but usually not joint bleeding. As I said, the difference with von Willebrand's disease, the problem is that the von Willebrand's factor, which is a type of factor 8, it's a byproduct of factor 8, that is required to adhere the platelet clot to the endothelial wall. When you get a breach in the endothelial wall, then platelets clump together, and then they have to attach to the endothelial wall in some way, and they do that by using von Willebrand's factor or von Willebrand's factor 8. That combines to plug up the hole in the endothelial cell wall, and so the blood vessel wall. If you get a breach in the blood vessel wall, we're all the time we're having a little bit of bleeding into our skin, but that usually the platelet clot is formed very quickly, and if we've got enough von Willebrand's factor, then the clot can just plug up the hole, and then everything's okay. But if you don't have enough von Willebrand's factor, then you have prolonged bleeding time. That is, it's a test that can be done to measure how long it takes for the blood to clot. The bleeding time is prolonged, and the partial thrombus pressin time is sometimes prolonged, sometimes a bit prolonged, but sometimes it's just the bleeding time that's prolonged. Similar to haemophilia, the treatment is replacing factor 8 or von Willebrand's factor, and you can do that using fresh whole blood or fresh frozen plasma or von Willebrand's factor 8 concentrate, and that can be again a pooled multi-donor von Willebrand's factor, or these days it's a recombinant, what we call recombinant factor, von Willebrand's factor concentrate, and that comes just in a vial, and it's highly effective. Sometimes in children with mild or moderate bleeding, they can get DDAVP, so arginine vasopressin, and that releases, if you've got some von Willebrand's factor, that releases the stored von Willebrand's factor into the bloodstream and can then stop bleeding. The main thing is fresh whole blood or fresh frozen plasma or von Willebrand's factor 8. I wanted to talk about other causes of bleeding. So we've talked about ITP, we've talked about haemophilia, and we've talked about von Willebrand's disease. There are some nutritional causes of bleeding as well, and the two main ones are vitamin K deficiency and vitamin C deficiency. And this is a child who had vitamin C deficiency, and that's scurvy. It's probably more common than we think, and it occurs in children who are malnourished or deficient in vitamin C. And you can recognize that this is the typical gum appearance of a child with scurvy. The gums seem to be a bit hypertrophied and thickened and bleeding. And they have a raised petechial rash on their skin, and they sometimes have joint swelling, and particularly of the knees, especially of the knees, and they'll hold their knees in a fixed flexion position, and when you try to straighten their knees out, then it's very painful for them. Sometimes they also have pulmonary hypertension because vitamin C is involved in nitric oxide production, and we all need nitric oxide to lower the pulmonary vascular resistance in our lungs. don't worry too much about that. That's off the topic of bleeding, but it's another feature of scurvy and vitamin C deficiency that we see. This is the X-ray of a child. Well, this is the knees of a child who has scurvy, and you can see that they're swollen. Both of them are swollen, and this is the X-ray, and you can see that there's the bony cortex of the femur. This is the knee joint, the femur, and the tibia and the fibula. And I just want you to look at the bony cortex. The bony cortex looks normal down to the metaphysis here, and just near the epiphysis, you can see it's all rather a bit ragged. It's a bit ragged. It's not smooth like in the tibia. It looks relatively smooth, but here it looks quite ragged. And that's the typical features of the typical bony appearance of a child who has scurvy. Can also occur in children with rickets or vitamin D deficiency, and it can sometimes occur in children with syphilis. So the differential diagnosis of this appearance on X-ray includes scurvy, leukemia, syphilis, and vitamin D deficiency. But this was a child who had gum bleeding and a petechial rash and this knee joint swelling, so clearly had vitamin C deficiency. And this child's diet had not been having any vitamin C for a long time. And just to know that what foods you need to take on a regular basis to get some vitamin C, and they include oranges, citrus fruits, grapefruits, they are rich in vitamin C. Strawberries are, kiwi fruit, some vegetables, broccoli, cabbage, capsicum, those red or green capsicum, and tomatoes. They're all rich in vitamin C. And if you have some of those in your diet, then it's unlikely you'll be vitamin C deficient. But if you have a diet that contains no fruits and vegetables, then you're quite likely to become vitamin C deficient over time. The treatment for this is simply vitamin C replacement and correct their diet and or give them vitamin C tablets, which you can get from the pharmacy. With this child that I've just shown the X-ray and the photograph of, he had severe pulmonary hypertension, and within 48 hours, 2 to 3 days of having vitamin C, the pulmonary hypertension completely resolved and he was well again. So it can have a dramatic effect on a child's clinical state, on bleeding, and also on their systemic respiratory function as well. Now, I want to talk about vitamin K deficiency now and talk a bit about this condition called hemorrhagic disease of the newborn. That's used to be very common, and that's why, of course, we give vitamin K to all babies at the time of birth. And it's important to know why we give vitamin K, why it is that we give vitamin K, and whereas we don't necessarily give other vitamins. Well, babies have very little vitamin K at the time of birth. It's only small amounts are transmitted through the placenta from their mothers, and it's usually late in the third trimester that you get vitamin K transmitted through the placenta, a bit like iron. And the coagulation factors that are produced by the liver, they rapidly decline in the first 2 to 3 days of life, and you need vitamin K to replenish those vitamin K factors, those vitamin K dependent coagulation factors. There are in our bodies, there are bacteria in our gastrointestinal tract. There are bacteria that produce vitamin K, but in a newborn's intestines, those bacteria are not there. So the baby's not getting much from the mother through the placenta. The coagulation factors that need vitamin K are declining very rapidly, and the bacteria that make vitamin K are not present in the newborn's intestines just yet until a baby that doesn't have bacteria in the gastrointestinal tract and then has to acquire those bacteria through the first few days of life. But if there's no bacteria there, then those bacteria are not producing vitamin K. And then breast milk, human breast milk, mother's milk, contains fairly low amounts of vitamin K. That's why we need to give vitamin K to all babies, especially breastfed babies, at the time of birth. And then there are some other babies that are more at risk of vitamin K deficiency, and that is where the mothers are on certain medications. Like if they're on isoniazid the mother's on isoniazid for TB treatment, or on anticonvulsants like phenytoin or carbamazepine, then they're quite likely to be more at risk of what we call early onset severe hemorrhagic disease of the newborn. Usually, for most children, they don't get it in the first 48 hours, but it comes somewhere between 2 days and 7 days, and sometimes even late onset, beyond a week of life, 2 to 6 weeks of life. It's hemorrhagic disease of the newborn is sort of broken down into 3 different phases. I alluded to them just before, but early onset in the first 24 hours is usually due to maternal medications as well as not getting vitamin K. But if the mother, as I said, has been on anticonvulsant medications or isoniazid, then her levels of vitamin K will be very low, and then nothing will be transmitted across the placenta to the baby, and the baby may get early onset hemorrhagic disease of the newborn. That typically it's somewhere between 2 and 7 days, and that's just with bruising or umbilical cord hemorrhage. And then late onset hemorrhagic disease of the newborn occurs in children who haven't been given vitamin K at the time of birth, and about a third to a half of them present with intracranial hemorrhage. It can be very severe. So usually in vitamin K deficiency, the INR is prolonged, the prothrombin is prolonged, and the partial thromboplastin time is prolonged. But it's usually the history that will give the diagnosis away. And you need to find out whether the baby's had vitamin K at birth, and if not, or anyway, just treat them with vitamin K if their INR or their prothrombin time is prolonged. As I said, you can get vitamin K deficiency in older children. It's not only in neonates, but it also occurs in malnourished children, in those with malabsorption, so they're not absorbing the vitamin K, or those with liver disease, because you need the bile salts for absorption of fat-soluble vitamins. And the fat-soluble vitamins are vitamin A, vitamin D, vitamin E, and vitamin K. And so children who have liver disease, especially if they have cholestasis, so not just hepatitis, but cholestasis, and they've got high levels of conjugated bilirubin, they're quite likely to have vitamin K deficiency, and that will contribute to a prolonged prothrombin time and to a high INR, a long INR, which international normalization ratio. That's another indirect measure of the prothrombin time, and they are likely to have significant bleeding. The liver also makes the coagulation factors, so it's not just vitamin K deficiency, but if a child's got liver disease, then their liver may not be making the coagulation factors well. And if a child goes into severe liver failure, then they're likely to have a combination of vitamin K deficiency and also liver dysfunction, causing a lack of synthetic function and a lack of production of vitamin K and the coagulation factors. Those children with vitamin K deficiency, they'll particularly have a high INR and a prolonged prothrombin time. And the treatment is just vitamin K, just intramuscular vitamin K or oral vitamin K, can be given intravenously as well. And if I usually think if the child's got a coagulopathy, if they've got thrombocytopenia, if they've got purpura or petechiae or bruising on their skin, then I'm reluctant to give them an intramuscular injection. So just giving them it intravenously is good. It can work fairly quickly. Within about 48 hours, you can replenish the vitamin K dependent coagulation factors, and their coagulation should be normal, unless they've got an ongoing cause for vitamin K deficiency, like malabsorption, or like they're on isoniazid, or they're on anticonvulsants, or they've got liver disease. Usually, if it's just nutritional, then their vitamin K stores will be replenished after a daily dose for several days. This is a child These are two children who had, as you can see on the left-hand side, this is a newborn baby. You can still see the umbilical clamp there, and you can see the purpura. These are purpuric spots on the legs. And the other child is an older girl, 6 months of age, who presented with this severe purpuric bleeding. And this is what's sometimes called purpura fulminans. That means fulminant purpura. And sometimes it's just called disseminated intravascular coagulation. I think that's probably the more accurate term. It used to be called purpura fulminans. These patients have both bleeding and clotting. So they've got bleeding into their skin. You can tell they've got bleeding into their skin, but they also have clotting, excessive clotting. And it's usually the clotting that starts the process because they have some cause for primary abnormal clotting, whether it's a severe infection. Both of these children had a severe infection. The child on the left had Pseudomonas septicemia, and the child on the right had Neisseria meningitis, meningococcal septic shock. And so these two conditions were gram-negative septicemia, causing what we call a hypercoagulable state. That is, they're more likely to clot. And the various conditions lead to a hypercoagulable state, but typically severe bacterial infection. And these patients, when they clot a lot, they get consumption of all their clotting factors. They get consumed and their platelets get consumed. And because of that consumption of their coagulation factors and their platelets, then they're more at risk of bleeding. And so it can happen very quickly, and it can rapidly progress from just a clot in the hand or the limb, and can progress to purpura fulminans, like fulminant purpuric lesions. And that's because they have a systemic hypercoagulable state. They're more likely to clot and therefore consume all their clotting factors and then get bleeding. The treatment for it is to make the underlying diagnosis, make whatever the underlying diagnosis is you need to identify. But you can diagnose the disseminated intravascular coagulation by all their coagulation markers are abnormal. Their prothrombin time will be long, their partial thromboplastin time will be long, their fibrinogen will be very low because they've consumed all their fibrinogen, their platelets will be low because they've consumed their platelets, and they often have what's called a high D dimer, which means they've got, as well as clotting, they've got breakdown of their clot, breakdown of clots frequently, and that leads to the breakdown of the clots leads to a high D dimers or high fibrin split products. So everything about the coagulation screen is abnormal. High prolonged prothrombin time, prolonged partial thromboplastin time, very low fibrinogen, very low platelets, and a high D dimers. That's how you tell a child has DIC, or you can tell them clinically if they appear like the children that I showed you before. The most common and important cause is meningococcal disease, but it can occur from other infections, from other forms of bacterial septicemia. I've shown you a child who's got Pseudomonas septicemia and DIC, and it can occur in even viral infections like varicella. Chickenpox can give you a DIC picture in its most severe forms. Measles can give you a very severe DIC form, again, in its most severe forms, and that's sometimes called black measles, where you get purpura all over the body. That's, again, very severe end of the spectrum of these conditions. There's a form of leukemia that can give you DIC, and it's called promyelocytic leukemia, acute promyelocytic leukemia, and that can cause severe DIC at presentation. And sometimes they look like children have got meningococcal disease, but they actually have leukemia. And then there's two other conditions that can give you a hypercoagulable state, and that is if you've got low levels of protein C or protein S. And protein C and protein S, they inactivate the coagulation factors. And if you've got no protein C or S, then you've got hyperactivation of coagulation factors number 5 and 8. And if you get hypercoagulation or hyperactivation of these coagulation factors, then you get a hypercoagulable state and you get all the features of DIC. And so most typically, if you see a child with this condition of DIC, then most likely they've got meningococcal disease or some other form of septicemia. You need to rule out leukemia by doing a blood film and then just think of the other viruses that might cause it, varicella or measles. Usually you can diagnose those clinically. And then occasionally you see a child who's got an inherited or acquired form of protein C deficiency or protein S deficiency, and that can result in a hypercoagulable state. Just lastly, I wanted to touch on a couple of other causes of excessive bleeding, because we do see this quite a lot. And this is a child who's got Hinoch-Schönlein purpura, and they can look a lot like children who've got meningococcal disease. Their skin can look like that, but they're not that unwell. They're not so toxic. They're not in septic shock like the child I showed you before. They often have joint pains or arthralgia, arthritis or arthralgia. They often have abdominal pain because the same purpuric lesions they have on their skin are also in their gastrointestinal tract. And sometimes, quite commonly, they have hematuria and nephritis, and they have a form of glomerulonephritis. This is an autoimmune condition that leads to purpuric lesions, abdominal pain, gastrointestinal bleeding, and joint pains and arthritis and arthralgia. And it's not common, but it's good to be able to diagnose it so that they don't get treated like they've got meningococcal disease, because usually they're relatively well. They can talk to you. They're not in shock. They don't have signs of severe cardiovascular disturbance. Most of these children with Hinoch-Schönlein purpura will get better over about 6 weeks, but about 10% go on to have chronic glomerulonephritis. Usually, they only need symptomatic treatment. They usually don't need steroids or other treatment. Steroids don't really work on the nephritis, which is the most troubling part of the HSP. Steroids sometimes works when you've got severe abdominal symptoms, severe abdominal pain. Sometimes steroids can work, but usually we just monitor these patients, manage their nephritis, so manage their hypertension, fluid restrict them, or give them whatever fluid they need to maintain euvolemia, and treat their arthritis or arthralgia with simple analgesia. That's really how they get treated. And then lastly, I just wanted to mention a common cause of bleeding, and that is the sequestration of platelets. And maybe sequestration's a new word, but it just means platelets get hidden within usually the spleen. And when you've got a child who's got a severe tropical splenomegaly syndrome and they've got a massive splenomegaly, then they may become thrombocytopenic because they sequester platelets within the spleen. The spleen consumes the platelets, and those patients with chronic malaria, tropical splenomegaly syndrome may have thrombocytopenia for a long time because of this. Also, children who have a big spleen because they've got sickle cell disease or thalassemia. Certainly it occurs very commonly in sickle cell disease and less commonly in children with thalassemia. But if you see a child with thalassemia who's got thrombocytopenia, then most likely they've got sequestered platelets into their big spleen. And occasionally you see children with portal hypertension who've got secondary splenomegaly who sequester platelets into their spleen and they become thrombocytopenic, and they might get petechiae, or bruising. The treatment for it is to identify the underlying cause. Usually with sequestered platelets, children don't bleed too much, and usually the platelets remain above 30,000 as long as they don't have any other cause of thrombocytopenia. Then usually they don't need platelet transfusions. But again, a child who's got thrombocytopenia and a big spleen, we need to exclude leukemia, as well as considering they might have sequestered platelets. So you need to identify and treat the underlying cause. And if their platelet count is very low, less than 20,000, then certainly they need to be transfused. But often the lifespan of platelets in a child with splenomegaly is quite short, because they too get sequestered within the transfused platelets get sequestered within the spleen. I just briefly mentioned dengue as a last condition that causes thrombocytopenia, not usually because of sequestered platelets, but it's just part of the dengue syndrome, and that's part of the differential diagnosis of ITP, or thrombocytopenia, or sequestration of platelets. So we talked today about different conditions that lead to excessive bleeding in children. We've talked about acquired conditions, about ITP. We talked about inherited conditions, so hemophilia and von Willebrand's disease. We've talked about nutritional problems like vitamin K deficiency, which can occur at the time of birth, or it can occur because of some illness that the child has, liver disease or malabsorption. And we talked about vitamin C deficiency, so scurvy, and we talked about disseminated intravascular coagulation, and we talked about sequestration of platelets. So they're the common reasons why we might see children with excessive bleeding. And that's all I wanted to say today. That's the first time we've had a discussion about excessive bleeding in children, and I just thought it's worth covering that today. So I'm going to stop recording.